So welcome to our 19th live webinar on orthopedic principles. This time, our guest is Dr. Krishna Kumar from Hull, UK. You would have known about Hull for its deformity courses. Dr. KK is favorably called as KK, and he completed his post-graduation at Trivandrum Medical College. He moved to Qatar and worked there for 10 years before moving to the UK. He was president of the IMA at Qatar. He went on to do a fellowship in Singapore, and then he finished yet another fellowship at Nottingham, UK. He completed his FRCS trauma and Orth and the EBOT exams. He's a trainer for the Wrightington FRCS upper limb course and is an upper limb consultant at Hull and East Yorkshire NHS Trust. He's going to talk about how to get enrolled into higher surgical training in the UK. Over to you, Dr. Krishna Kumar. You can share your screen.
Yeah. Hi, Hitesh. Thanks for having me. Just give me a second while I share the screen with you. Right. Okay. So can you see my screen now?
Yes, it's clear.
Okay, great. So hello, everyone. Krishna here. So we are going to talk about basically the CSER today, which is the Certificate Eligibility for Specialist Registration. And I'm going to take it as some of you who have just completed your post-graduation and you're looking to move to the UK and what your career options are, all right? If you're finished orthopedic training in your home country and you're wondering what to do next, this can really be a confusing time. Your options are you can work in your home country, you can go for a fellowship abroad, Europe, North America, Australia, popular destinations. You can go to the Middle East, Singapore, or New Zealand. Or you can choose to work in the UK. Now, I'm not going to sit and talk about the pros and cons of each place and what to do. That's beyond the scope of this talk. But if you do want to come to the UK, the first thing you need to do is get your GMC registration. The General Medical Council here is the regulatory organization for all doctors, and everyone who works here has to be registered. There are 4 pathways by which this can be done. 1, you can do your PLAB exam and clear it. Second, you can be sponsored by a GMC approved sponsor. Now, this is commonly any of the UK hospitals. So here the hospitals are called trusts. So if a trust sponsors you, then the GMC will accept your registration. Third, if you have an acceptable postgraduate qualification, if you have done your MRCS post 3 years, or if you have your FRCS, then that's fine. The number 4th and the most difficult route is the eligibility for entry to the specialist register. And that's what we're going to focus on today. Now, the jobs in UK, particularly if you go to NHS jobs and look, can be very confusing because there are about 5 or 6 titles, all right? Now, let's look at them. The common one is FY1, CT1, CT2. It basically means Foundation Year 1 and 2 or Core Trainee 1 and 2. Previously, this was known as SHO or Senior House Officer. This term is no longer officially used, although you can hear it very often in the wards and A&E still. Second, if you have already completed your D-Ortho, the second pathway by which people come is as an IMG, which is an international medical graduate. You come here on a 2-year visa, which is commonly Tier 5. You work for 2 years, you establish a relationship with one of the hospitals, and then you can go back and come back again as in a permanent setting. Now, 3, 4, and 5, they're basically the same. Trust registrar, clinical fellow, and specialty doctor. All these 3 are basically middle grade jobs. The difference is in the salary. The specialty doctor post attracts a sort of higher salary. You tend to get more of a permanent contract, and the salary is negotiable as well. Generally for trust registrar and clinical fellow, you tend to get 1-year contracts, which then need to be renewed. Associate specialist is actually, this was a term reserved for someone who is very senior, who is had a lot of surgical experience and who can sort of independently handle an orthopedic unit. It's just one step short of consultant. This post was abolished, but it's now started to make a comeback. Of course, the option everyone looks for is to go for the training pathway. If you get into a training pathway, well and good. If you don't, then that's where CSER comes in. Now, the ultimate aim of all these jobs is to get onto the GMC specialist register. Now, you might wonder, what is this register about? It's basically a group of doctors, and only if you get on the register do you become eligible to become a substantive, or otherwise called a permanent consultant in the UK. If you are not on the register, you can at best be a locum consultant, and that's a temporary job with a contract which needs to be renewed, etc. Now, what are the ways to get on the specialist register? If you go and read the GMC site, you will get a myriad of about 8 ways to do it. This can often be quite confusing. So to put it very simply, there are just 2 ways. Number 1, go through the training pathway. It takes about 8 years. And at the end of it, you get a CCT, which is a certificate of completion of training. If you go all other pathways, the non-training pathway, go through the CSER. This can be a variable period from a minimum of 1 year up to an N number of years. It just depends how long you take to complete it. And that's how you get the CSER. There are advantages, pros and cons of each. And again, that's possibly slightly outside the scope of this discussion, but generally what people in the UK tend to do is they try and get into training. If it's not possible, you do a CSER. Another option is if you have already done a lot of your training abroad and you have ample experience while coming, you may find the CSER is easier and it takes less time for you to finish than going through the training pathway. Okay. Now, if you take a shot at an emperor, you have to kill him. That's what Emerson said. CSER is very true. This is one subject where you do not make a half-hearted attempt. When you go for CSER, you have to give it everything you have. As the old movie saying goes, you don't take a knife to a gunfight. Now, movie quotes apart, I'm going to ask, these are some of the common questions I normally get asked by people wanting to go for the CSER pathway. The first one is, where do I start? Now, for surgical candidates, particularly orthopedics, I would say start with your logbooks. I'm going to talk more about logbooks further on here, and I'll tell you where about it, because that's the one which takes time to finish and to complete. Yeah. Another good place to start is also slowly building up on your CV, and we'll be talking more about the CV in the next few slides. The second question I get asked is, can I do CSER in 6 months? The short answer is no. You need to work at least a year in the UK, and that's what the statistics show. You need to work at least a year for you to have a reasonable chance at getting your CSER application across. The statistics, the data also shows that if you work for 3 years, your chances become much more, and the numbers are more in your favor, actually. How much time will it take for me to do CSER is a very personalized question. It depends on you, your level of training, what you have done, what more is left for you to do in terms of the requirements. So that depends. Number 4 is basically, again, a personal choice. Should you apply for training or should you go for CSER? As I said, if you are someone who's just finished your training abroad, you're still young, it's worth coming and trying for a training pathway here. If not, if you have already had a lot of ample experience, CSER is probably a better option for you. But again, that's a very generalized way of looking at things. This is a decision which you need to introspect and make for yourself. Yeah. Last one, CSER for me, that's again a variation of the same question. Okay. Now, if you're going for the CSER pathway, these are the 5 sites which you really need to know. There's the General Medical Council, there's the JCST, the ISCP, which is the Intercollegiate Surgical Curriculum, the electronic logbook, which you do need to have. And last is a biased opinion, but that's my own CSER UK YouTube channel. You will find a lot of videos, 10, 12 videos in a lot of detail if you wish to go in. Now, what all do you need for CSER? Number 1 is grit. Now, the Americans like to call it as grit. Here in UK, we call it resilience. It basically means one and the same. You need to persevere and you need to keep going in spite of the odds. As the old saying goes, if you're going through hell, just keep going. Yeah. Family support. Do not underestimate the importance of having a supportive family. The amount of work needed to input and clear a CSER application is tremendous. It's not an exaggeration when you say that this is the world's biggest application form and often runs into 1,500 to 2,000 pages. Finances can be a problem. In the UK system, the trainees get priority in terms of allocation. So you may find that at one point, your hospital is not able to support you with your subspecialty, and you may need to switch hospitals for the same. Last but not the least, but what was most important for me was generous amounts of whiskey, but whatever works for you. Now, how am I eligible for a CSER? All you need is your orthopedic postgraduate qualification from your home country, whatever it is, MS, D-Ortho, DNB. It can be from anywhere, and all you need is a documentation. Yeah. Now let's start with the CSER CV. A CSER CV is unlike any other CV you would normally prepare for a job. It commonly runs to 25 to 40 pages. That's what the recommendation is. The common mistake people make is they take their normal job CV and then try and make a CSER CV out of it. This is something you should not do. Start with a new CV from scratch, and it's a CV which has to match your application form exactly. I'll talk a bit more about it later on. You need to use standard templates. The GMC will give you a standard template for your CV, and I will give you my personal template as well in the next 2 slides. Now, the fourth thing is don't change your titles or job descriptions. For example, if you were working abroad as, say, a junior consultant or as a specialist, when you apply for CSER, that's the exact thing you need to keep it as. Keep the same wording, junior consultant or specialist. Do not try and change it to a UK-based format. Yeah. Include your subspecialty experience in your CV. So one thing the British training system looks at is you have ample experience in each subspecialty: pediatrics, foot and ankle, spine, upper limb, hip and knee, and so on. So include a little summary about each, and include short descriptions of each job where you worked in. Yeah. Now, the most important thing I can tell you about your CV is be honest. Nothing puts off a prospective employer more than the fact that they find that you've been short selling them on your CV. It looks very bad, and the GMC will call your probity into question. Okay. So this slide shows what the GMC wants you to do in terms of the format for your curriculum vitae. Now, what I did for my application, I tweaked this a little bit, and this was actually my CV's format. As you can see, the last page is 38, so it ran into 38 pages. So I included personal details. Your registration details basically mean which surgical body you're registered with. Your professional medical qualifications, they're self-explanatory. An employment chart is actually very good. They want all your employment right from the time of finishing your postgraduate training. So if you have worked in about 4 or 5 places as I have, you need to put them all with the dates as well. The subspecialty experience means you write a little bit about each subspecialty and what your experience in it is. Research and publications is self-explanatory, as are presentations. Courses relevant to curriculum can be two. There are essential courses, which I'll talk about later, and the other courses which you normally attend as part of your CPD. Any national or international orthopedic conference can fit in this criteria. Audits is UK specialty. Again, I would say teaching and training experience needs to be included, meetings and conferences, management skills, and last but not the least, referees. Now, how do you apply for your CSER? You go to GMC Online, you just have to Google it, you create an account, and you apply. And that's what you get when you open GMC Online. So on the left side, you will see a list of qualifications. You click each one, it'll give you a subset of things which you need to fill out, and each one can then be completed. So as you can see, it goes on to become a very, very big application once you start doing it. The good thing about the GMC Online application is it's free to do, and you don't have to make the payment till the very end. So what I did was I opened the GMC Online, made an application and started applying, and then I saw what evidence was needed and what was required of me. So then I worked backwards from it and started to supplement, if that makes sense. Yeah. Now, another important site for you to know is that of the JCST, and of that you need to know about trauma and orthopedic surgery only. I've just highlighted that for you. This basically gives you 4 domains. Now you are going to submit your evidence in these 4 domains, and domain 1, which is knowledge, skills, and performance, constitutes 75% of your evidence. Yeah. Here you're going to talk about your logbooks, your appraisals, your PBAs, CBDs, educational skills, etc. Domain 2 is basically safety and quality. A lot of this involves audits and clinical governance, and this is only 15% of the evidence. Number 3 is communication, partnership, and teamwork. It's just 5%, as is domain 4, which is maintaining trust. And that's a lot more to do with honesty, probity, etc., and sort of character references. Now, there's an evidence checklist, which you need to know. What I'll be doing now is I will share my screen with you, and I'm going to show you an example of an evidence checklist. So if you can see the screen, this is the evidence checklist which you'll get. Okay, this is basically domain 1, what we spoke about, your primary qualifications, secondary qualifications, honors and prices. You need to give 360-degree feedback, appraisals, assessments. Logbooks are a very important part of it. I'll talk about it in the logbook section in detail. Medical reports and case histories are not very relevant for orthopedic surgery applications. Yeah. You need to give details of your posts, your employment letters, contracts of employment, research, publications, CPDs, teaching, and training. Now, as you can see, that whole thing was domain 1, and that's quite a lot. So it's about 75% of what you're going to put in. Domain 2 is basically safety and quality. It's basically your audits and your clinical governance. Yeah. And domain 3 is these are the evidence that you need in terms of checklists, partnerships, teamwork. And domain 4 is trust, where you talk about honesty and integrity. Okay. Now we'll go back to the main presentation. Good. So let me play that. Right. Now, in the domain 1 evidence, your intercollegiate exam is the current gold standard. For you, this means the FRCS orthopedics. If you don't have the FRCS orthopedics, or like some people, if you're unfortunate that you have not managed to clear it in your 4 attempts, Some people try with other exams like European board, etc. But the threshold of evidence required to submit in the absence of an FRCS is very, very high. So if you don't have an FRCS, what you need to do is you need to collect all the evidences of knowledge which is required in the syllabus, and you need to provide documentation that you have achieved each bit of knowledge. And as you can see, that can become a very, very painful exercise to do. So I strongly urge you, if you can do your FRCS Orth and clear it, that's the best way forwards. FRCS international exam, which is now available outside the UK, at the moment is being accepted. Now, this is not set in stone, and this is something that may change. And the information I have is as per a verbal conversation and an email sent to a colleague of mine from the General Medical Council. Now, the catch with the FRCS International is it can only be written by someone outside the UK. From a practical perspective, I can tell you that the FRCS International is much, much easier to pass and clear than the FRCS Ortho in the UK. The pass percentage for FRCS Ortho in the UK for a non-trainee is only about 20%. Yeah. For an FRCS International, as per the data we have, it's in the range of about 80%. So there's a clear difference there. European training is currently accepted in the UK, but Brexit has happened. And just like any nasty divorce, we are still not sure which is going where. So we'll have to keep our eyes peeled. Now, I hope you all remember Dante, and he said, "Abandon all hope, ye who enter here." I'm going to tell you about a few terms which are sort of unique to the UK and which you kind of need to know. Yeah. Number one is these three: PBA, CBD, MSF. PBA basically refers to a procedure-based assessment. CBD refers to a case-based discussion. MSF means multi-source feedback. I'm going to talk about each one of these in a bit, all right? Audits, as I've told you about, is basically a review of your own practice. You compare it to a national standard, and then you see what improvements can be made for your practice. Clinical governance, again, I'm going to show you a little slide that explains it a little better. Appraisals basically is something very similar to an annual performance review. That means at the end of 1 year, you sit down with your supervisor, you have an appraisal, you go through what all you have done, what all you could have done better, the courses you attended, the teaching you have done, what complaints you had, if any, what compliments, what you hope to achieve. All this forms part of an appraisal, and it's very standard in the UK. NHS management is something which is sort of unique. The NHS, as you know, is one of the largest employers in the world. And its structure and organization is something which actually you need to attend a whole day's course in order to understand how it works. But before you decide to come to the UK, it's worth attending a course on NHS management to understand the structure and function. Complaints are surprisingly common. If you're not getting a complaint, it probably means you're not doing enough work. And how to handle complaints and respond to them is an article by itself. Reflection is something else which is rather unique to the UK. So we all tend to do a lot of reflections. This can be on anything. You can reflect on a case which has gone wrong. You can reflect on a complication which has happened. You can reflect on a course which you have attended. You can reflect on a conference or topic which affected you. So there's no limit to which what you can reflect on. Currently in the UK, due to the Bava Garba case, there are some legal issues surrounding reflection. And what it basically means is whatever you reflect on, the idea is to keep the patient data anonymized so that it doesn't create an issue later. Service development is something which is a part of NHS management actually, but it's something they look very keenly on. And if you come and you offer ideas in the UK about service development, the managers here will just love you for it. Probity, it basically refers to your honesty, character. And that's something that's very, very important here in the UK. Now, what I'm going to do is I'm just again going to share my screen with you guys, and I'm going to show you about the PBAs and CBDs and MSF and what it means. Yeah. So let's start with a PBA. It's basically a procedure-based assessment. So for example, if you're going to do a hip hemiarthroplasty and I'm going to supervise you, yeah, I'm the assessor. We assess a large number of things other than just the fact that you have done an operation, okay? So one, you need to know the theory about it. You know the complications, you know the processes, and you have taken an informed consent from the patient. And we look at the pre-op planning, how you did the operation team briefing, whether you anticipated any complications, did you check the patient's site, did you position the patient properly, etc. The pre-op preparation again includes the fact that the positioning, the skin preparation, how you drape the operative field, how you arrange your general equipment. The actual surgery comes in part D only. Your skin incision, your surgical dissection, did you achieve a sound repair? Yeah. And whether you followed a protocol, if you had a complication, were you able to handle it well? Did you use an assistant to the best of times? Did you communicate clearly? And last but not the least, we can look at your operation note, whether you left clear instructions and you ensured that the patient was safely transferred. Now, all these needs to be assessed when you do a surgery, and you're given 4 grades. Level 0 means there's no evidence and clearly you're unsafe. Level 1 is you were unable to perform the procedure, even under supervision, which means we had to take over. Number 2, you were able to perform under supervision, but you needed a lot of assistance. Level 3 is you were able to perform the procedure, but you needed an occasional assistance in between, say help in one single step or 2, which is fine. Level 4 is where you're competent to perform unsupervised and you can handle complications. Level 4 has now been classified into 4A and 4B, and it goes on into detail, but this is what a procedure-based assessment means. And you need PBAs for practically about 40 of them per year, along with case-based discussions. So that means at the end of 6 years, when you submit your CSER application, you need about 200 to 240 of these. Yeah. Now, I'm going to go to the CBDs, okay? So CBD basically means it's a case-based discussion. So we have had a case and then you're going to discuss about it. You've discussed your general strengths, developmental needs, recommended actions, word keeping, and there are standard indications in cases where a CBD is needed, all right? So it goes into a lot of detail, and I'm not going into the particular detail of each over here. The next thing I'm going to focus on is the MSF. Now, what happens in an MSF is it's basically a multi-source feedback. This is my own MSF from a few years ago. So you have to send out these forms to all your colleagues, and that means it's a 360-degree assessment. You send it to your consultants, you send it to your colleagues, you send it to your juniors, you send it to your nursing staff, you send it to the housekeeping staff, and practically everyone whom you interact with. So you get a sort of global opinion about it. The current recommendations are you need to do an MSF every year. When I completed my CSER, we had to do about 2 or 3 in 6 years, but now you need to do about 3. So that's it, I'm afraid. So that much for MSF. Now, yes, I did promise I would speak about clinical governance. And this is what, beg your pardon, that's the, not the governance, excuse me there. So clinical governance is this. Okay, so that's going to the, back to the other one. That's not what I meant. Yeah, so there you go. So clinical governance is basically this little chart which I want you to see. Yeah. So this These 7 things basically form clinical governance. It basically means how your NHS organization constantly improves itself by all input. Now, you get input from clinical audits, you get input from education, you get input from clinical effectiveness, information technology, patient experience, staff management, and risk management. It's worth knowing about clinical governance if you're coming to work in the UK. And from my experience of working in several healthcare systems, I can tell you that the NHS does take clinical governance very seriously. And I haven't seen another health system which gives so much focus on clinical governance as the NHS does. Yeah. So that's just to give you an idea in detail. Now, yeah, since I think we have covered all what I wanted to, so that's basically, we're going back to the original presentation now. I've spoken a bit about reflection, service development, and probity there. So moving on. Yeah, I'm pretty sure you remember this scene. Now, you all remember the scene from the Terminator where the storm is coming. And for your CSER application, you have a perfect storm coming with your assessments and appraisal section. That's where your PBA comes in. Now, you remember we saw what a PBA was and a procedure-based assessment. Some of the common reasons, and it's one of the reasons why people fail their CSER application, because you saw the amount of detail that had to be put in for a single surgery. Now, most trainers, they tend to give just block ticks and go. So if you just give a block entry of several ticks, it's just not enough. You need to get your trainer to write comments on it, to write where you can improve, what you did well, and you need to get that actually written onto the PBA. And without it, your PBA is regarded as not being meaningful. And that's one of the difficult things to do. So as I said, meaningful completion, and it should show evidence of progression. So for example, in your training, if you have started doing a total hip replacement, yeah, the first total hip you do, we don't expect you to get anything more than a grade 2 or a grade 3 if you're really very good. But what they want to see is when you start with a grade 2 and grade 3, and over the years you progress, and at the end of 5-6 years, you should get a grade 4. And that evidence of progression should be reflected in your PBAs. And that can be evidenced only by written comments. Yeah. Now, yeah, what we spoke about. Now, another thing that has been added is you now need multiple grade 4 assessments from different trainers, not from just one, but you need 2 or 3 people signing it and telling you that you're good and that you can do a total hip replacement independently without complications. Your PBA and logbook need to be cross-referenced very, very strictly. Yeah. Now, if most of you are very sincere and you have your e-logbook, the best way to do it is to enter your logbook the same day you do your operation. Now, like most of us, we don't do it. If you're someone who does it at the end of 6 months, like me, what will happen is you will tend to miss out on some of the dates particularly, and the dates will go wrong. You may submit a PBA and that may not match with your logbook. And so that's when the cross-referencing comes into play. The second thing you need to be careful of is with independent operations. So there are some people here in the UK who have worked here for several years. They're very experienced, they operate independently. And the difficulty for them to do CSER is if you're operating independently, you cannot actually get a PBA filled by someone. because a PBA has to be filled by someone who has seen you operate, who either supervises your operation, either by scrubbing in or at least by being in theater. You can't have someone, a supervisor, being at home filling in a PBA for you. So that's one difficulty which you need to keep in mind. Now, you need to remember that as a first surgeon, you need to do at least 70% of the procedure. Yeah. So let's go back to the example of the total hip. Okay. You need to do the incision and the approach. Say for the acetabular component, maybe your supervisor does it. If you do the femoral component and if you do the closure, you have still done 75% of the operation. So you can write the procedure in your name. Yeah. And like I said, multiple assessments. MSFs, as I said, you need now every year, yeah, unlike the 2 to 3 years. Now, the common mistakes are your assessments are not detailed enough, or there are not enough numbers and not enough evidence supplied, and no evidence of progression. Again, if you don't have the number of required mandatory assessments, I honestly urge you, do not submit your application. Nothing irritates the committee more than finding out that you haven't got the required number for all the required procedures. So if you don't have it, wait till you get it and then submit it. Like I said, you get only one shot at the king and you need to make it count. Again, other mistakes are it's not presented well enough. There are no summary sheets. You don't have your minimum numbers, or it's not arranged well. So what I mean by summary sheets are sheets like these on the left-hand side. So when I submitted my CSER application, I had 31 PBAs for trauma, 20 CBDs for trauma, making it sort of 51 assessments for trauma. Upper limb was similar. The MAND means to the mandatory PBAs and the mandatory CBDs, and I'll be speaking about them again. Pediatrics again refers to 9 and 15, hip and knee again 9 and 11, foot and ankle 11, 11, and spine, so on. Oh, the good thing to remember is they don't really expect you to have done a discectomy, or they don't expect you to do a pedicle screw fixation, but you need to have assisted in it. And if you have enough case-based discussions, that's fine. It's good to go through the JCST site. It'll give you further details on what they are looking for. For example, they expect you to operate at least 3 times a week, yeah, to have 3 sessions and 2 clinic sessions per week. You need to have an annual statement of no probity issues. Like I said, honesty and character are taken very seriously here. You need to have ample evidence of multi-source feedback. And the next one is about the mandatory CBDs. So these are the mandatory case-based discussions which are required. There are about 14 of them. This list has just recently been updated a few months back, I believe. You'll notice that there's quite a lot of spine in there. So if you look at number 4 to 8, a lot of it is spine, and it's really difficult to get these amount of CBDs or case-based assessments completed without actually doing a posting in spine. And that's why it's important to do a spine rotation, at least for a few months, so you can get this sorted. Some people do manage, they go to spine courses and get the CBDs done. It's still accepted. Okay, so that's one way to go around it. Now, this is one of the most painful things you'll ever receive, which is an actual CSER rejection letter. Well, on the positive side, they write in detail and tell you where you have gone wrong. But after all that effort, pain, and stress, it can be rather painful to read it. So if you read this particular letter, they tell you what's gone wrong is your work-based assessments are not meaningful. They should show evidence of progression. They should show evidence of guidance. They should include comments. Yeah. And in this particular case, the logbook was not presented in a structured manner. So for simple, and their recommendation was they wanted this particular candidate to do at least another 12 months in further post. And that again means a lot. Now, appraisals, I said these are very similar to annual performance reviews. You need 6 appraisals, 1 per year. And there are some places where they don't do appraisals. So what do? In that case, at least a letter from your supervising consultant, which covers all the aspects in the appraisal, will still suffice, and the GMC will accept those. Okay. Logbooks, these are the second most painful part of your CSER application. Yeah, there's a lot to talk about it. And when I talked about logbook, a friend of mine actually told me this. He said there are 3 types of lies. One is white lies, the other one is true lies, and the third are logbooks. What I said, be very honest in your logbooks, write what's there, and probity can really be an issue. Now, we come to the exciting part of it. I'm going to tell you these are the indicative groups surgeries, yeah, which means you need PBAs for these surgeries, and you need these many numbers completed in 6 years' time. Okay, so let's go through one. So you need major joint arthroplasty. Now, previously, this was divided into total hips and total knees, and I needed to do 40 hips and 40 knees as a first surgeon before submitting my CSER application. But now they have changed it to major joint, which means I'm an upper limb surgeon, so I can include all my shoulder arthroplasties in this. It doesn't necessarily have to be hips or knees. But in 6 years' time, I need 80 arthroplasty surgeries as first surgeon. It's not enough to assist and write it in your name. You need to be doing the procedure, and you might need a PBA as well, although you don't need 80 PBAs. Yeah. The second is osteotomies. So most people use the HTOs or the distal femoral osteotomies for it. Nerve decompressions, previously it was 30, and now it's come down to 20. Arthroscopies, previously I believe it was about 40, it's come to 50. Arthroscopy can be of any joint. It can be knee, shoulder, ankle, elbow. You need to do about 50 DHSs and about 40 hemiarthroplasties. And you need only 5 external fixators, which is very good. It's come down quite a lot, actually. Going down the list, tendon repairs has come down to 10. Last year, it was about 20. And I know that a lot of colleagues struggle to get tendon repair here in the UK. It's not very common. Intramedullary nailing comes to 30. Plate fixation, you need to do 40. It can be for forearm fractures, or even for ankle fracture platings can be included. Tension band fixation, again, is not very common. So patella or olecranon fractures can be put. They've recently included K-wire fixation for fractures, which you will have a lot of here. There's a lot of distal radiuses which gets treated with K-wires. And children's displaced supracondylar fracture, also you need 5. So my point is, before you submit your CSER application, you need to have all these numbers done. And all these have to be done within a 6-year period. If you are someone who's had a career for over 10 years or 15 years, and if you have all these number of cases, but they are distributed over 15 years, then that doesn't help. You need to have these within that exact 6-year time period before you're submitting the application. This is a very important point, so I hope you take note of this. Yeah, a lot of people have been caught out on this. So I'll repeat again, you need to achieve all these numbers within the 6-year period prior to application submission. Okay, good. These are some of the other cases which you need to do, but you do not need to be the first surgeon here. Yeah. So you need to have experience in arthroscopy, shoulder stabilization, joint replacement, elbow. The thing is, when you submit your application, especially for CSER, you should not have a 0 in any of these. What you don't want to do is go and say that, okay, you have done a lot of spine and hips, but you haven't done a joint replacement elbow, or you haven't assisted a joint replacement elbow. So I know a colleague of mine who actually went to another hospital. He took 1 day's leave, went to another hospital, assisted a joint replacement elbow, so he could just tick that box and get it off his list. Yeah. Other elective cases you need to do are with knee, arthroscopy, ACLs, you need to have assisted foot and ankle. You need to do first ray surgery, 20 of them. So you need exposure in foot and ankle. You need exposure in pediatrics and childhood pelvises as well. And that's again for the trauma bit. Okay, good. The common mistakes which people make are not giving the 6 years logbook exactly. I've already spoken about this. Anonymization, hiding the patient identifier details is something the GMC really frowns on. So you need to make sure that all data, particularly with regard to patients, are anonymized. If you have gaps in your career, then you need to adjust your logbooks according to the gaps. For example, I had a 3-month break between my jobs. So when I submitted my 6-year logbook, I added the 3 months prior to submission so that the total logbook came to only 6 years, if that makes sense. The logbook should reflect your breadth of experience. Okay, it should cover all aspects of orthopedics. Use summary sheets, like I've shown you before, what a summary sheet is. So use them so that the examiners can see what you're doing, and keep your logbooks at 6 months or 1 year intervals so that it's very easy for them to go through stage by stage. Yeah. Yeah, as I've spoken to you earlier about anonymization, this is what you need to anonymize. Any patient details, any patient addresses, any contact phone numbers, NHS numbers, or individual patient numbers. You don't need to anonymize gender. You don't need to anonymize date of birth. Yeah. So this is very important, and the GMC will actually return your application if you send it in without anonymization. Now we come to research. You need to complete what's called a good clinical practice course on research. It's something unique to the UK. And I can tell you from experience that they really look forward to having the UK course done. I know of colleagues who have done research methodology courses which were done in the United States, but this was not accepted by the committee because there's a lot of research methodology which is sort of unique to the UK, and they kind of expect you to be well versed in it before you submit your application. Yeah. Now you need to do journal clubs. I had a friend whose application was rejected recently because there was no evidence of journal club activity. Now you also need to complete 2 of the following. You need authorship of 2 PubMed cited papers. Okay, so that's something you really need to work on. Sometimes it can be very difficult to get articles published, as you know. It's not important. Now, people often ask me, does my publication have to be in a top-notch journal? I mean, not necessarily, but it doesn't mean that you should just submit it to any local journal which comes by. If you can't get it published in a top-notch journal, I would encourage you to put more publications in a journal, in any other reasonable medium-sized journal with an average impact factor. You need 2 presentations at national or international meetings, which over a 6-year period should be all right for most of you. You need evidence of recruiting patients into a research study or a higher degree, but most people tend to do the authorship and the 2 presentations. Yeah, good. Now, when you do your authorship, you should try and be at least the first author, or that's ideal. If you can't, you can at least be a second author. Okay, or the research methodology. Oh, there's another thing I wanted to speak about is the research methodology course, and it needs to be UK based. Again, I know of people who have done a research methodology course outside, and it's been rejected by the GMC. So you need to do research methodology courses which are UK based courses. Common mistakes: the clinical good practice course needs to be within the last 3 years. Yeah, if it's expired, if it's beyond 3 years, they'll ask you to do it again. Journal club, I've told you about. When you submit your research article, make sure you include the entire article. Yeah, letters to the editor can be included, and you can also be part of a trial for recruitment. Now, another thing I used was a GMC CPD app. This is freely available on your smartphone. Yeah, and you can just download the app. The good thing about this app is when you input a course, yeah, it automatically lets you classify it into the 4 domains. You remember I spoke about the 4 domains: knowledge, skills, safety, communication, etc. So when it automatically does that, when you finally print out your CPDs, it makes it very easy for the GMC to assess. It's all categorized sections and puts into assessments, and it makes their job very easy. So just download this app. It's on your iPhone or Android. It's free to use, and you need roughly about 40 to 50 points per year. Okay. Teaching and training, another important part. Whenever you do a teaching session, you need to do at least 1 or 2 sessions per year, every year for 6 years. Every time you do a session, try and get a form like this. It's easily available online. Just Google teaching feedback. If you don't have if your organization doesn't have a teaching feedback format, you can just make one online and get it validated by your educational supervisor. Give it to your students or your trainees at the end of it and get feedback from them. Okay, that feedback is very important. Letters from colleagues or comments from people complimenting you on your teaching sessions can be used. Now, yeah, audits is the one which you do need to talk about. It's actually, I think it's if I remember correctly, it's the 4th or 5th common reason why CSIR applications fail. The main reason is there is not sufficient number of audits, or the audit is incomplete, or your audit only focuses on one area and doesn't go across the breadth of the curriculum. Okay, this was from a GMC review of 2016. Now, there's a lot to talk about here. All these are things like reflection, safety, honesty, skills, leadership, diversity, equality, chairing meetings. All these are things to be filled in your CSIR application. Yeah. Like I told Hitesh at the beginning of this, this probably might require another session to just go through these in detail, but broadly skimming through, most of these are self-explanatory. I've told you what service improvement means and sharing data protection, but these are things which you are very easy to get once you are in the UK. There are data protection courses, there are equality, diversity courses. Most of your hospitals will have a course. Just attend the course, get your certificate. And if you upload the certificate, that requirement, that checkbox is ticked essentially. Now, before you submit your application, you need 4 referees. I would say try and get at least 5 or 6 so that you get at least 4 sent in. It's not as easy as you think, and it's always safer to have more referees than less. 2 referees should work in your specialty. They should be from orthopedics, and 1 referee must be your medical director. Now, let's look at the success rates of CSIR application. This is over 3 years, 2016, 17, and 18. This is not for orthopedics, mind you. This is for all specialties in general. And you'll see the success rates are roughly slightly over 50%. Yeah, it stays the same. Now let's look at orthopedics. See the bottom, orthopedics about 40% success rate when you apply for the first time, all right? But when you apply for the second time and you put in a review application, the number goes up to 90%. This is where I go back to my original point about grit. You may fail in your CSER, but if you persist, the chance of you succeeding is very, very high. Okay. Now, after hearing all this, if you're looking like those two characters, I really don't blame you. It's a lot to take in. There's a lot of information to collate, and people often feel disheartened that it seems that there's too much to do and you can't go forwards. My answer to that is take it step by step, go piece by piece, take it one day at a time, and you'll slowly progress. Now, I'm going to tell you the top 10 reasons why people fail in CSER. This is my own top 10. Number 10 is what I call a single hospital application bias. Yeah. Now, a UK trainee, when they train in a region, they work in at least 6 or 7 different hospitals. So they go to each hospital every year. They do one subspecialty there, then go to the next one. So they have an ample exposure. On the contrary, people who do CSER applications tend to work only in one hospital. And this is something that the committee really doesn't approve of. They want you to work in a wide area and have an ample exposure before you put in your application. Before I put in my application, I had worked in about 6-7 hospitals in Singapore, Qatar, Nottingham, Leeds, etc. So, my training more or less matched that requirement, but that's something you just need to be aware of. Number 9 is lack of communication skills and lack of MSF. People's CSER applications have been put down just because these were not there, okay? So you need to make sure that your communication skills documentation is quite up to date. Lack of current evidence. So they are not bothered if you have done a lot of work before 6 years. What they are interested is in exactly what you have done in the last 6 years, and of that, within the last 3 years, okay? So recent evidence within the last 3 years has much more value than evidence before 6 years, if that makes sense, okay? Number 7 is mandatory courses. There are a number of, like I said, the NHS Leadership and Management course, the Communication Skills course, ATLS, or Teach the Teacher, Train the Trainer. These are all mandatory courses you do need to do before you submit your application. Number 6 is research. Like I said, you need to have those 2 articles, 2 presentations, or be part of a trial, or do the research methodology course by the Royal College of Surgeons of England. Audit, like I said, there are the GMC review, which I mentioned before. There are 3 places where the audits can fail. You need to have audits. 2 of your audits need to be loop completing, and you need to be sure that the loop is completed, and you need to submit complete evidence of your audit application. Like if it's as a PowerPoint, you need to submit your original audit, and then you need to submit the PowerPoint of your re-audit so that they can check and make sure that your re-audit has been done, okay? Number 4 is incomplete assessments. Like I said, if your PBAs and CBDs are not meaningful, it will be rejected. Number 3 is the logbook. As I said, if it's not formatted or there's lack of summary sheets, this can be a problem. Number 2 is poor organization of evidence. If you see this little cubicle block, all these blocks integrate, and it forms one solid cohesive unit. And that's what's actually needed in a CSER application. You need to use dividers, summary sheets, cross-reference, but don't duplicate. But the number 1 reason why a majority of CSER applications fail is lack of evidence across the whole of the curriculum. Most people submitting CSER application tend to be subspecialized in one part of orthopedics, They may be good in pediatrics, they may be good in either trauma, and they may be good in spine, but they do lack in the rest of it. And that's where most CSER applications fail. So remember, before you submit, you need to tick all the boxes. Last but not the least, don't forget Murphy's Law. If you think everything is perfect, you'll probably missed something. And that it's not probably, you have surely missed something. That's Murphy's Law for you. So before you apply, read the specialty specific guidance. Yeah, if you don't have the evidence, wait till you can get it. Like I said, your CSER application can come to about 1,500. Mine came to 1,900 pages of documentary evidence. Don't duplicate evidence. Don't put the same evidence again and again, but instead cross-reference it. So if they ask for the same evidence in another part, you can just cross-reference it and say, please check this section, and they will check. Okay. And see the 4 domains, which I said, and the percentage of evidence required for each. Yeah. So this is what happens when you apply. So now let's imagine that you have finally done all these years of hard work. It's 6 years down the line. You have submitted your CSER application to the GMC. You have paid the money. Within the first week or so, they'll get back to you with an email, and they'll give you 14 days to submit your documents. By the way, the CSER process has become completely online now. So all document submission is electronic, which means you have the painful part of scanning each document and uploading it. And there are a lot of tricks about it, which I will tell you probably in a subsequent session. So once they receive this evidence, within 1 month, they'll come back to you with a checklist. Oh, you might think that you have given the most perfect application there is, but trust me, they will find something. And you have then 2 months time to finish what the requirements they asked of you and to give your application back. So once they accept it, so 3 months time has gone now, okay? They then send this to the Royal College for approval. And the Royal College sends it back within about 6 weeks or 7 weeks back to the GMC, who then does a verification of your application for about 6 weeks. And in 6 months' time, you will have an answer, whether you've made it or not. Okay, so that's just a rough timeline. It usually takes about 6 months from the time you apply to get a reply back from the GMC. Let's look at the cost. The initial application is £1,600. Review applications a further 600. All the mandatory courses are about £2,000. If you want to change jobs, for you, it will cost about £2,000. Now remember, if you are there with family, you need to change visas for your family as well. So add the 2,000 with the number of your family members, all right? But the cost of the trauma, stress, and strain, it's priceless. Now, dealing with the GMC, all this data, because when I came to the UK about 4 or 5 years ago, I mean, I found a distinct lack of practical advice on the CSER application. There was a lot of theory out there. There was a lot of material to read. A lot of it did not make sense. I did not have a place where I could ask doubts. And so my source of getting information was from the GMC. And a lot of what you have seen in the last 1 hour of presentation is the feedback I got from the GMC and my own personal experience put in. So when you call the GMC for advice, mostly you will be put through the primary team. If you have a specialist query, you will be put to the specialist applications team. Now, there are not many of them. There are only about 12 or 14 to my knowledge. So the specialist applications team are actually fairly busy, and they will respond to you only if the primary team cannot answer your query. Sometimes neither of them are able to answer your query, in which case you can call the JCST directly. They are very helpful as well. Okay. That is my YouTube channel. It's CSER UK, and that's the link. If you just type CSER UK YouTube on Google, you'll get it. That's what it looks like. There are about 14, 15 videos which go into a lot more detail. And yeah, that's it there. Hitesh?
Yeah, thank you, Krishna, for that exhaustive but complete information. It was
Yeah,
actually, you have covered almost everything. If someone wants to come to the UK, how to go about it. So that was really nice of you. And
sure.
because the reason I'm saying is most of the guys who go to the UK, they wouldn't help others to come over. That's the normal phenomenon what I've seen.
Yeah,
So I'm really happy that there is a person who's does the opposite. He is trying to help people to come to the UK. And
yeah. No, I'm happy to help. I just didn't want others to go through what the difficulty I went through. And if this helps someone in some way, I'm more than happy.
I know the those words, those are really important. Was perseverance, resilience, hard work,
Mm,
and never die attitude.
yeah, yeah, very true, actually, very true.
Okay, and
Are there any questions, Hitesh? Oh,
yeah, the other interesting thing was you said that you should be, it is the longest application, the biggest
oh,
application
yeah,
in the world. Interesting.
yeah,
Yeah, so there are a couple of questions. Yeah, I'll read out to you. This
yeah.
is one from Dr. Puneet Prakash from Jamshedpur, Jharkhand.
Okay.
And he finished his MS in 2018.
Mm,
Question is, it goes like this. I've completed my MS, want to complete my FRCS trauma and Orth from UK and have some experience working at NHS. So what should be the pathway plan and then applying for a specialty? How do I proceed?
yeah. So, like I said, if you have done your MS, you need to do your FRCS. At the current moment, you the FRCS International Orthopedics can be written in India. Okay, so you just need three signatures from any three of your supervisors to write it. Like I said, the pass percentage for an FRCS International is very high at the moment, and at the current moment, it is being accepted for CSER applications. Okay, but Puneet, what I cannot promise is by the time you come here, you start your work, whether that ruling will change, then it's quite possible it might change. So if you look at it that way, the others, a safer option would be if you want to try and to write the FRCS ortho here in the UK. For that, you will have to come here and work for about 2, 3 years. You can request your seniors to countersign your application for you. I should make it quite clear at this point. It is not very easy to get signatures for your FRCS ortho in the UK. Yeah, your supervisors need to be sure that you have attained the standard of an ST7, ST8 trainee, and that you are well versed and you're able to write it. Only then will you get signed off. So what I would urge you to do, Puneet, is to think about which is the safer option and take it accordingly.
Okay, thank you, Krishna, for that answer. And you know what? There's one more query that are we able to do the international affairs all parts from India or
Yes, yeah. You don't need to come to the UK at all for doing a FRCS Ortho International. You can do it. I'm not sure about India whether there's an exam center there, but I know that there is in Malaysia and I know that there is in Qatar or somewhere in the Middle East. So there are places, but it can be done outside the UK for sure.
okay? Is it similar to what happened years before the intercollegiate MRCS?
Yeah,
Is it something
yeah.
similar what's happening?
Yeah, it's a bit that way. I mean, I'm not getting into the decisions for why the exam was exported. But what I can tell you is the FRCS Ortho in UK, the chance of passing it the first time for a non-trainee is only 20%. Yeah, whereas the FRCS Ortho International has a much higher pass percentage and it's much easier to pass.
Okay, so that is good. So all these guys should write the FRCS International
Yeah,
outside if they're outside the UK.
yeah. At the moment, it seems to be a good option because they are considered equivalent. So, I mean, I don't know anyone who has got their CSER application yet by writing the FRCS Ortho, but you should, if you are planning to write the FRCS Ortho, you should do it before you come to the UK, because you cannot write that exam when you're working in the UK, the international one. Yeah, you can write the local one if you get signed off for it.
Okay, so if you're in the UK, if you're attached to the NHS, you can't write the international FRCs, right?
Correct.
Okay, they can come back to India and write and go back again.
Yeah, it's a long route, but
Yeah. So yeah, so there's another question by Mr. Atif Mohammed, and his question is, how many journal club entries do we need?
yeah. So, like I said, what happens in the UK is you have a journal club usually once every 3-4 months. Okay. So, while there is no fixed number saying you need so many journal clubs, what they basically want to see is whether you match the training given to a UK trainee exactly. All right. So, if a UK trainee is doing a journal club, say every 2-3 months, so you have, say, 2 or 3 journal clubs a year, you should provide an evidence of at least 15 to 20 journal clubs over the period of 6 years. And it's a very simple matter to do a journal club. It's if there's no organized journal club in your institute, you can set it up yourself, get a good topic, get a good article, get a people to discuss it, get a consultant in that subspecialty. For example, calcaneal fractures, open reduction, internal fixation, or percutaneous. Take a topic, discuss it, and document it. So ultimately, the CSER application is a lot about documentation, as you have understood from the lecture.
Okay, so that was good. The other question is by Raza Hassan. Is it necessary that various rotations internationally should be within 6 years as you worked abroad?
Yeah, everything has to be within 6 years. Any rotation which is outside 6 years usually is not considered. So, I mean, although all these rotations do not have to be in the UK. Yeah. For example, when I applied for my CSER, I had worked in the UK for just 3 years. The remaining 3 years were in Singapore and Qatar. So I did my part of my shoulder in Singapore. I did a pediatrics and trauma in Qatar. I had done a bit of spine in Qatar. So that's how the whole thing sort of came together. But it has to be within 6 years exactly.
Okay, Krishna, I think there are no more questions, and
Okay,
it's going to be archived, so they can ask the questions later on, and whenever you're free, you can respond to them.
that's fine.
And now that you have given your link, so they can come to you and they can ask you questions as well. So I think it's almost complete. And thank you once again for joining us for this 19th live webinar on orthopedic
Yeah,
principles. It has been an honor to be with you. And I really appreciate the perseverance and the resilience that you have taken after working for 10 years in Qatar and then moving to the UK after doing a
yeah,
fellowship in Singapore. That was really amazing of you. And thank you once again. And I look forward for an FRCS class from you
yeah,
because you're
sure.
an FRCS upper limb trainer and writing
Yeah,
trainer. So we look
no
forward for
problem.
that. So I think I'll be able to host you within a week.
You'll see. Yeah, happy to help. Yeah, sure.
Okay,
Good
thank
luck
you
to
very much.
everyone.
You have anything to say?
No, I just want to say thank you for the opportunity, and
Yeah,
just want to wish everyone good luck with it. Like I said, the CSER is something which is definitely doable. You just need grit and you just need to persevere with it. Yeah.
yeah. Thank
Okay.
you so much,
All
Krishna.
right.
I'll
Great
end
stuff.
it.
Thank you. Bye bye.